welcome to the deep dive. You know, when you or, say, a loved one gets a medical implant or some kind of synthetic filler, there's this, well, there's a fundamental assumption that I think most of us operate on.
Right, yeah.
You assume that once the doctor places that material in your tissue, it just stays exactly where it was put.
Exactly.
It's a bit like placing a book on a shelf.
Yeah.
You close the patient up, and the expectation is that, decades later, you could open them back up and find that material sitting right there, completely unchanged.
Yeah, I mean, we inherently want medicine to function like masonry.
Yeah. Right.
You lay the brick stays. But the reality is that the human body does not passively accept foreign materials.
Not all.
The internal environment is highly dynamic, and honestly, it's biomechanically aggressive. It interacts with these materials, it subjects them to immense mechanical stress, and in a lot of cases, it fundamentally transforms them.
Which is wild to think about. So our mission today is to explore a very specific, really fascinating intersection of technology and human physiology where that whole book on a shelf assumption just completely shatters.
Totally falls apart, yeah.
We are looking at a stack of medical research on how 3D pelvic ultrasound is revolutionizing the way doctors evaluate treatments for stress urinary incontinence.
Right.
Specifically, how it tracks the longevity and the exact submucosal position of injected bulking agents over time. We're talking about the high-tech diagnostic detective work that's required to actually understand the post-operative reality of these procedures for patients.
Yeah, it's incredible technology.
Okay, let's unpack this. We're looking at bulking agents like polyacrylamide hydrogel.
Which is known clinically as Bulkamid.
Right, Bulkamid, or particulate injectables like macroplastique. And the clinical goal here is optimal urethral coaptation, meaning the precise placement of these fillers into the urethral submucosa is just absolutely critical for increasing resistance to urinary flow to stop leaks.
Exactly. I mean, the physical mechanics of this rely entirely on creating those artificial submucosal cushions.
Right.
Because in a patient with stress urinary incontinence, the intrinsic sphincter deficiency means the anatomical valve is failing under intra-abdominal pressure.
So like when you cough or exercise.
Right, exactly.
Yeah.
So by injecting these synthetic gels into the submucosal layer, the doctor is basically attempting to manually increase the tissue volume. They want to seal the urethral lumen from the inside out.
I always visualize the mechanics of this, like putting a can of Fix-A-Flat into a leaking bicycle tire.
Oh, that's a good way to look at it.
Yeah, because the tire has a structural gap, right?
Yeah.
And it's losing pressure.
Right.
So you introduce this thick foam inside to expand the interior wall and just sort of seal the gap using outward pressure.
That's conceptually very close, yeah.
But I want to push back on the imaging part for a second, because the sources heavily emphasize the shift toward endovaginal and transperineal 3D ultrasound.
Right.
Why is the three-dimensional aspect strictly necessary? I mean, from a diagnostic standpoint, couldn't a doctor just look at a standard 2D ultrasound and see this, giant blob of collagen or gel sitting there?
Well, the limitation of 2D ultrasound in this specific application, it's that it fundamentally relies on flat slices.
Okay.
If an operator is relying on a 2D view, they're only capturing a highly localized cross-section of what is actually a really complex asymmetrical structure.
Because it's not just a perfect little circle in there.
Exactly. When a bulking agent is injected into the submucosa, it rarely distributes into some mathematically perfect sphere. It pools irregularly, mostly based on localized tissue compliance.
Oh, I see.
So a 2D slice might display a thick, robust deposit of material, which gives this false impression of, adequate volume and great placement.
But it's lying to you.
Right, because just 2 millimeters away, outside that one specific focal plane, the material might be completely absent, meaning the urethra is totally unsupported on one side.
So the 2D slice is inherently deceptive because it strips away all the spatial geometry. You might see cross-section A and it looks perfect, but you're totally missing the fact that cross-section B is just an empty void.
Precisely. What's fascinating here is how 3D ultrasound actually circumvents that limitation by acquiring a comprehensive volumetric data set.
So they can see the whole thing at once.
Yeah, the operator can manipulate that volume, slicing it in the coronal, sagittal, and axial planes all at the same time.
Wow.
Using what they call the stacked contour method, doctors can trace the irregular borders of the injected gel across multiple sequential slices.
Oh, so they kind of build a 3D model of it.
Basically, yes. The software reconstructs the true total volume and, more importantly, its exact spatial relationship to the urethra.
Which is the whole point.
Right, because the clinical data strongly correlates long-term continence with a very specific morphological distribution. Specifically, the optimal horseshoe shape.
A horseshoe. Okay, so it needs to wrap around.
Exactly. The bulking agent needs to wrap circumferentially around the urethra to provide uniform pressure.
Makes sense.
An asymmetric deposit might just compress the urethra unilaterally. It just pushes it to the side rather than actually sealing it. And you can really only confirm that critical horseshoe shape through multiplanar 3D imaging.
Well, sure, seeing that perfect horseshoe geometry on the monitor immediately after surgery is great. But the real mystery, and really the core focus of the clinical data we're looking at today, is what happens weeks or months after the patient goes home.
Right.
Because going back to our initial premise, you assume the injected hydrogel is going to maintain its volume and stay put.
And the longitudinal data completely upends that assumption.
Yeah.
And when you track these patients out to the 90-day mark, the ultrasound data reveals massive anomalies with both volume and position.
Yeah, the pilot study out of Aalborg University is a perfect example of this. They tracked a cohort of women treated with polyacrylamide hydrogel.
BAHG, right?
Right. And they did the 3D ultrasound analysis immediately post-injection and then again at a 3-month follow-up. And the data showed a mean volume loss of 36.5% in just 90 days.
Which is staggering.
Over a third of the injected filler was just gone.
Yeah.
And furthermore, they tracked the distinct deposits. Out of 53 separate injection pockets that they identified right after the procedure, only 41 were detectable at 3 months.
That's a 23% disappearance rate.
Right. A 36% reduction in total volume over a single quarter is a massive anomaly, especially since PHG is engineered specifically to be non-biodegradable, right?
Exactly. It's supposed to be highly stable in tissue.
So here's where it gets really interesting. Where did it go? Is the body metabolizing it like a dissolving stitch, or is it physically leaking out? Because it can't be metabolic degradation that fast, right?
No, it can't. The stability of the hydrogel strongly implies physical displacement rather than metabolic breakdown.
Okay, so it is physically moving.
Yeah, and the literature presents a few biomechanical theories for this rapid volume loss. The most prominent theory involves retrograde leakage through the injection tract.
Wait, meaning it leaks back out the hole the needle made?
Exactly. The doctor's introducing a needle into a very restricted space and injecting a viscous material under significant hydrostatic pressure.
Right.
When that needle is withdrawn, the puncture tract becomes the path of least resistance. So before the tissue has the necessary time to heal and seal the breach, a portion of the hydrogel is physically extruded right back out.
It's essentially a pressure differential problem. The pressure of the gel pocket exceeds the strength of the fresh puncture wound, so it just forces it out the back door.
That's one theory.
Yeah.
Another really compelling mechanism relates to mucosal compliance.
Which means what exactly?
Well, if the injected volume exceeds the tensile capacity of the surrounding tissue, the localized tension becomes too great. The overlying mucosa can literally rupture. Yeah, allowing the hydrogel to escape directly into the urethral lumen, where it's just subsequently washed away when the patient voids.
So they just pee it out?
Basically, it becomes this really delicate optimization problem during the procedure.
Yeah.
You need enough volume to achieve coaptation and seal the leak.
But if you over-pressurize it...
You guarantee tissue failure and you lose the material.
Man. There is also the mechanical reality of the pelvic floor to consider, right? Regarding the disappearance of those distinct deposits.
Oh, absolutely.
Like if a doctor places 4 distinct pockets of gel and the 90-day scan only shows 3, that missing deposit hasn't necessarily leaked out.
Right.
The sources suggest that the cyclical loading, just the physical compression from the surrounding pelvic muscles, could be forcing those separate deposits to merge together.
Yes, confluence.
Right. The tissue pressure causes a mechanical confluence. It squishes distinct pockets into a single continuous mass.
And that mechanical confluence theory aligns perfectly with just how dynamic the pelvic floor is. But, the most counterintuitive finding in that Aalborg data is actually the clinical outcome relative to the volume loss.
Right. I was just going to say this. Despite losing over a third of the injected volume and losing all those distinct deposits, 78.6% of the patients still maintained their symptomatic improvement.
Which is wild.
It's a paradox. The statistical analysis showed no direct correlation between the amount of bulking agent left, according to the 3D ultrasound, and how well the patient actually felt.
It feels like a paradox, yeah, but it actually reinforces this core concept.
Yeah.
Raw volume is secondary to structural geometry.
Okay, unpack that.
Well, if the body sheds 30% of the material, but the remaining 70% is perfectly distributed in that optimal horseshoe configuration we talked about.
The seal still works.
Exactly. The coaptive seal remains totally functional. Conversely, you could retain 100% of the volume, but if it shifts into some weird asymmetrical position, the mechanical seal fails and the patient is still incontinent. It's a powerful reminder that subjective patient surveys alone just cannot capture the underlying biomechanical reality.
Which is why the imaging is so crucial. Relying solely on a patient saying, "I feel better," leaves the doctor totally blind to the physical shifts happening beneath the tissue.
Absolutely. The integration of 3D ultrasound provides the subjective feedback loop that you really need to understand why a treatment is succeeding or failing.
Right.
And, that imaging capability brings us to the phenomenon of material tracking, which just further complicates this whole post-operative landscape.
The tracking phenomenon completely subverts the idea of a stable, localized injection. I mean, when looking at particulate materials like the study on macroplastique and coaptite.
The Showberry study, yeah.
Right. The doctors typically target specific anatomical coordinates, usually injecting at the 3 o'clock and 9 o'clock positions relative to the urethra.
Trying to create those spherical cushions.
But the 3D multiplanar imaging demonstrates that in 41% of cases, the material tracks, meaning it migrates linearly away from the intended site.
Yeah, the material just fails to maintain that localized spherical geometry. Instead of acting as a distinct supportive cushion pressing inward, it gets extruded along the fascial planes.
The biomechanics of the pelvic floor here really remind me of working with layered pastry dough.
Okay, I like this.
If you take a syringe, right, and inject a dense dollop of jelly into the center of heavily layered pastry dough, your goal is for it to sit there as a perfect little globe.
Right.
But the dough consists of distinct laminated layers. So the second you apply downward pressure on the pastry, that jelly instantly follows the path of least resistance.
It squishes out.
Exactly. It slides between the layers, flattens out, and just shoots off laterally.
That analogy perfectly captures the anatomical reality of fascial planes.
Thank you.
The pelvic tissues are highly anisotropic, meaning they have directional structural properties.
Okay.
So when a patient coughs, or walks, or does anything that spikes their intra-abdominal pressure, those tissues undergo intense cyclic loading. The injected agent gets squeezed between these fascial layers.
Just like the jelly.
Exactly. If the surrounding tissue resistance is lower horizontally than it is radially, the material is going to flatten out and track parallel to the urethra.
Wow.
And the literature notes that this tracking phenomena directly correlates with poor coaptation. Material that has tracked away from the sphincter is effectively wasted. It doesn't contribute to the mechanical seal at all.
So we've got substantial volume loss through leakage or rupture. We have material tracking along fascial planes.
Yep.
But the echogenicity data, this is what really stands out to me as the most profound transformation here.
Oh, absolutely.
Because we expect a water-based hydrogel like PAHG to remain hypoechoic on a scan. Because it has high water content, the ultrasound waves should just pass right through it, right?
Right, rendering it as a dark void on the monitor.
And immediately post-op, that is exactly what the data shows. 100% of the deposits present as hypoechoic. They're dark.
But then you look at the 3-month mark.
Right. The acoustic profile radically flips. Only 24% remain hypoechoic. The vast majority of these deposits transition to a bright, hyperpoic, solid appearance.
Which is a massive shift.
Why would a water-based gel suddenly look like a solid mass on an ultrasound? I mean, a hydrogel doesn't just spontaneously change its acoustic properties without a fundamental alteration to its internal density.
It doesn't. And this raises an important question about the long-term biological fate of these synthetic materials.
Yeah.
While the researchers themselves acknowledge that the exact mechanism behind this echogenicity shift needs more histopathological study, the prevailing hypothesis centers on aggressive tissue integration.
Meaning the body is actively remodeling it.
Exactly. The body isn't just ignoring this hydrogel. The biological response involves native fibroblasts actually migrating into the hydrogel matrix.
Wait, really? So it's essentially an infiltration process. The
Yeah.
surrounding tissue network is colonizing the synthetic filler.
That's exactly it. Over that 90-day period, the body begins depositing collagen and replacing the water content with dense cellular material.
Wow.
So that transition from a fluid-like dark acoustic signature to a dense, bright, tissue-like signature indicates that the body is synthesizing a fibrotic network inside the gel itself.
That's incredible.
The synthetic material is effectively being converted into a living, dense nodule of native tissue.
The physiological implications of that are staggering.
Yeah.
The implant is being fundamentally repurposed by the surrounding cellular environment.
Yep.
And this just drives home the necessity of the 3D imaging. Without it, doctors would be completely unaware that the implants they placed were losing a third of their mass, sliding down fascial planes, and being biologically converted into dense fibrotic tissue, all in 3 months.
It's a lot of morphological chaos.
Right. But with all this chaos, with the material shrinking, tracking, and changing density, how do doctors actually use this ultrasound to verify that the patient's anatomy is functioning? Because just looking at the shape doesn't confirm that the leak is fixed, right?
No, it doesn't. To confirm functional continence, the diagnostic approach has to transition from static morphology to dynamic anatomical assessment.
I mean, you can't just look at it at rest.
Exactly. Visualizing the urethra at rest provides incomplete data. You have to capture the anatomy while it's being subjected to the specific mechanical stressors that caused the leaks in the first place.
Right, which brings us to the concept of urethral funneling. This perfectly illustrates the shift to dynamic assessment.
Yes.
Utilizing the real-time capabilities of the 3D ultrasound, doctors visualize the bladder neck, the internal opening, while the patient performs a Valsalva maneuver.
Basically bearing down or coughing.
Right, bearing down to simulate the exact pressure spike that triggers a leak. Now, in normal continence, the sphincter resists this pressure, and the bladder neck stays tightly sealed.
Yeah.
But in cases of stress urinary incontinence, the pressure overpowers the valve. If the proximal urethra dilates and opens up more than 50% of the total urethral length, it is visually diagnosed as funneling.
Because it literally forms a funnel shape on the monitor.
Right, wide at the bladder neck and tapering down.
And the presence of that funneling under dynamic stress is the definitive visual marker of a failing support structure.
Okay.
So a successful intervention, whether that's a submucosal bulking agent or even a surgically placed midurethral sling, it has to visually eliminate this funneling.
So when they bear down, it doesn't open.
Right. When the patient performs the Valsalva maneuver post-treatment, the ultrasound should confirm the bladder neck remains closed. That proves the seal is structurally sound under pressure.
And the clinical outcomes linked to this visual feedback are incredibly stark. The data shows that patients who demonstrate no postoperative funneling achieve a 96.2% cure rate.
Which is fantastic.
But for patients who continue to display that funneling morphology under stress, the cure rate drops to 57.5%.
Huge difference.
Right. The visual presence of the funnel is a direct, objective predictor of clinical failure, and it supersedes whatever static volume of gel might still be visible.
Exactly. The clinical utility of observing this dynamic behavior is really pushing the whole field toward even more integrated feedback systems.
Like what?
Well, the literature points to combining this morphological 3D ultrasound data with dynamic URP.
URP being urethral retroresistance pressure.
Right.
So by measuring URP, the doctor is quantifying the exact amount of fluid pressure required to overcome the sphincter's resting tone and force fluid back into the bladder.
Yes. It's a precise numerical measurement of the valve's mechanical resistance.
So how do they combine them?
Well, the integration of these two modalities is a huge leap in precision. During the injection, the operator uses the 3D ultrasound to monitor the real-time formation of the agent, making sure they get that optimal horseshoe distribution.
Right.
But simultaneously, they're monitoring the URP values to quantify the actual mechanical resistance being generated.
Oh, wow. So they aren't just guessing the volume?
Exactly. The procedure shifts from injecting an arbitrary volume of hydrogel to actively titrating the volume based on real-time feedback.
That's incredible.
They only stop injecting when the ultrasound confirms the funneling is stopped and the URP monitor hits the target mechanical resistance.
It transitions the entire procedure from this blind inject and hope estimate into a highly calibrated intervention.
Yes.
So, for you, the listener, what does this all mean? The evolution of this diagnostic approach underscores a broader shift in modern medicine. The era of static resting scans is just increasingly inadequate for functional disorders.
Totally agree.
Whether it's the pelvic floor or any other load-bearing anatomy, confirming success requires dynamic proof. You don't just want a scan of your anatomy resting. You want a scan of your anatomy actively doing its job under stress.
If we connect this to the bigger picture, the integration of 3D ultrasound basically transforms the lower urinary tract from this hidden abstract tube into an observable mechanical valve.
Right.
By seeing the funneling stop, Doctors get objective proof that the endopelvic fascia and the support structures are actually stabilized.
And they get that proof regardless of the chaos happening with the filler itself?
Exactly. Whether the gel has shrunk or tracked away or turned into fibrotic tissue, the dynamic ultrasound cuts through all those variables to give a definitive verdict on whether the patient is cured.
It's the ultimate lie detector test for incontinence treatments. It maps out the exact volume loss, the tissue tracking, and proves whether the filler is actually preventing leaks. We have covered a tremendous amount of biomechanical ground today, really diving into how synthetic materials interact with our anatomy.
We really have. And the data presents a complex physiological landscape, but, it prompts a critical overarching realization for the listener that extends far beyond just urology.
Oh!
Yeah. We've just spent this time analyzing how a highly stable, non-biodegradable synthetic gel can lose 36% of its volume, migrate through dense tissue, and have its core density fundamentally rewritten by cellular infiltration, all in just 90 days.
Right, inside the pelvic floor.
Right. So if the human body is capable of this level of aggressive, relentless remodeling of a localized implant,
Yeah.
how might our bodies be quietly, systematically reshaping other synthetic materials that we consider permanent?
Oh, wow. That is a staggering implication because we operate under the assumption that things like joint replacements or surgical meshes or cosmetic fillers just remain pristine, sitting quietly like that book on a shelf.
But this data suggests a very different reality. The body is an active, persistent construction site.
Always working.
Always, unseen biological and mechanical forces are constantly interacting with these implants. So what invisible disappearing acts or fascial tracking or tissue transformations are occurring right now completely undetected just because we lack the localized 3D imaging to watch them happen?
It really forces a complete reevaluation of how we view the permanence of these medical interventions. The human body is never truly static. Well, thank you for joining us on this deep dive. Keep questioning the incredible dynamic mechanics of the human body, and remember that even when a procedure is considered complete, the biological integration has only just begun. We'll catch you next time.